I think it is, excuse me, in the interest of time, I will go ahead and introduce our guest speaker, Dr. Sergio Fazio, this afternoon. Dr. Fazio received his medical education as well as a PhD degree, MD PhD from University of Rome in Italy, where he also finished his residency and fellowship. He then came to University of California in San Francisco as a postdoctoral fellow, spent a few years there, and then later moved to Vanderbilt University in Nashville, Tennessee, as a faculty member. He rose through the ranks to become full professor of medicine there, as well as the director of preventive cardiology, and became very prominent in that field. A year ago, he moved to University of Oregon Health Sciences University and Knight Institute of Cardiovascular Diseases, where he is professor of physiology, professor of medicine, and pharmacology, and he also directs the preventive cardiology section within the Heart Institute there. He told me that he has 5 physicians within the preventive cardiology section, a physician assistant, 2 nurse practitioners, and a dietitian. So you can see he runs a big clinic, big program, and very active. He has published, he's a prolific writer, has published so many in premium journals. Right, his mind must be constantly speaking, get it out of the way kind of thing. Over 200 publications to his credit, and he's a reviewer of very many journals, and without much ado, I'd like to invite Dr. Fazio to give this talk on evolving strategies for LDL lowering in patients with hypercholesterolemia.
Thank you, Dr. Reddy. How are you? So I don't want anyone on the front row. And I'm just kidding. You know, normally, I don't know why you guys sit in the back always, huh? Look at the number of seats up front. So this is a presentation that comes from consensus, which is never a good word. So it's a presentation created by a group of people, including myself, to discuss on a storyline. And of course, this doesn't convey fully what I do in my place, okay? So I will try to be, I look at that scary sign there that says lectures end 10 minutes before the hour. I will try to finish 15 minutes before the hour and give you time for questions, okay? So I was talking to Dr. Reddy for a while, and that's where he got the information for my introduction, but I didn't tell him everything because it's never a good thing to tell you everything. So I have a couple of surprises for you, all right? So, I don't know, do you guys know Bill and Sonia Connor? I'm sure the endocrinologists remember the names. These are, Bill and Sonia Connor actually wrote together, a doctor and a dietitian wrote together the first book in the 70s about diet for health. Now they're everywhere, right? But they wrote the New American Diet book, and it was about eating to lower cholesterol, eating to improve your cardiovascular health. So I'm very proud to be the first William and Sonia Connor professor at OHSU. We cannot give lectures for companies, but we are allowed to do consultation work for some companies if our expertise fit their needs, and that's what I've done over the last 12 months. This is CME, as I said, and you know what it means. You get 1 hour, but you need to suffer by filling a couple of forms. And there is the pre-lecture form, and then you do it again, those test thingies. Gloria will tell you more information if you need it. And you may or may not know that a different speaker was at first scheduled to give this presentation. Mike Miller at the University of Maryland is a good friend of mine. He has long hair like me, but and we are covering pretty much the same slide deck. But you know, He also sees general cardiology patients, whereas I'm a little bit different. And so this is the pre-activity survey. So the one thing I didn't tell Dr. Reddy, because I didn't know if he will kick me out of the office, is that, I don't know how to say it, I'm not a cardiologist. I just act like one. I'm an endocrinologist, just like the guy behind you, okay? But the thing is, and the group of physicians I told you I run, I said they are doctors. I didn't tell you what type. And actually, 2 of them are endocrinologists, whom I moved from the endocrine division into the Knight Cardiovascular Institute. So the model of preventive cardiology I do is a model of, first of all, friendship between cardiology and endocrinology. Number 2, the house is in cardiology, but the expertise can come from everywhere. There are peripheral components to our practice, which include the chair of pediatric cardiology, who sees children with familial hypercholesterolemia. She's part of my group. The nephrologists who run the hypertension clinic are part of my group. Okay? There is a family medicine doctor who specializes in preventive cardiology. He's part of our group. So it's a very large core group with everything else that is preventive cardiology at OHSU, part of our umbrella. But so at Vanderbilt, I was doing the same. So when I joined Vanderbilt University in 1993, I joined the endocrine division, and I started a lipid clinic in the endocrine division. In 1999, I moved it to cardiology with the blessing of the department chair. I still remember the day that the new director of cardiology came to me in endocrinology saying, move your practice to cardiology. And I said, you must be crazier than you look, because it's a big thing you're asking me to do. Eric Nielsen was the chairman of medicine, and he blessed it. He says, it's one family, it has to find a better home. And the better home, I was convinced then and then convinced now, it's in cardiology. So it's interesting to hear that you don't have a dedicated preventive cardiology program here, and you say, we don't see many of these patients. It's if you build it, they will come. These patients are everywhere. You just need to have the structure, the reception system for these patients, and then you become as large as congestive heart failure. There is no reason why preventive cardiology has to be a little appendix in cardiology. Actually, we are aiming in Oregon at seeing more patients than all the other sections in cardiology. All right. So the objectives here, after all this is make it sound. I just give you background on what I do and what I know, so that your questions are in line with my expertise. But the conversation here is about LDL management, what guidelines say, what the medications that we have at hand allow us to do, what new medications have come into the market, what new medications may come into the market, and how this affects your practice. Okay? So, you know the guidelines. These have been very controversial, lots of conferences, lots of dispute, many people aggravated to, probably beyond reasonable argumentation about these guidelines. But one way or another, in 2013, AHA and ACC agreed to endorse a previous set of guidelines that was originally sponsored by the NIH. Okay? Remember that this was supposed to be the newest incarnation of NIH guidelines, and then the NIH decided not to support guidelines anymore, just to provide evidentiary information for agencies to produce. Get the first row, guys. No, okay. I think it's just a tradition. Okay, but so the new guidelines, if you can simplify them, they say what type of statins to give to whom. Okay, those are not lipid guidelines. They are not preventive cardiology guidelines. They are LDL management guidelines or statin utilization guidelines. Okay, and they say there are 4 groups of people that need statins: people who have atherosclerosis-based cardiovascular disease, people whose LDL is freaky. Do you know what an LDL of 190 marks with likelihood? familial hypercholesterolemia, all the scoring systems for the diagnosis of familial hypercholesterolemia include an LDL above 190. So you read LDL above 190, you should read people who are likely to have an inherited severe hypercholesterolemia. People who have, remember when diabetes was a coronary risk equivalent? Now there is a little modifier. There is an age modifier, and of course there is an LDL modifier that encompasses every single number. And then there is this most controversial group, which is everybody else, whose risk calculation places them into a 10-year risk of 7.5% or higher, and there is really not telling how they came up with 7.5, right? Before it was 10%, then they put it down to 7.5, thus capturing a much larger number of people that qualify for therapy. And what is therapy? They basically endorse 2 statins, atorvastatin, which is, as you know, has been generic for a long time, so maybe $2 or $3 a month, and rosuvastatin, which is branded but not for long, but it can cost, it depends on where it is on the formulary, it can cost as much as, in Oregon, I discovered that can cost up to $120 a month, okay? But these are the 2 endorsed at high dose, 40 and 80 for atorvastatin, 20 and 40 for rosuvastatin. Then there is not much of an endorsement for what they call low intensity, okay? And the other endorsed group is moderate intensity, and there is a longer list including lower dosages of atorvastatin and rosuvastatin. There is simvastatin at 20 and 40. For full disclosure, I take simvastatin 40 milligrams a day because I tried atorvastatin, I didn't react well, and simvastatin I pay $2.65 a month, and it takes care of my LDL quite well. Okay, so if you ask the rest of the world and they come to us and say, why did the American guidelines stray so much from the historic trend? And our answer at conferences is always, what American guidelines? Oh, you mean the AHA, ACC guidelines, right? The Endocrine Society hasn't changed the guidelines. So the Endocrine Society still stays with the LDL goals. The National Lipid Association stays with gold. The American Diabetes Association hasn't changed. So even in the US, there is not full consensus that we need to do it according to AHA and ACC. Of course, cardiologists follow the ACC and the AHA, but in general, you just need to consider that there is a spectrum of guidelines out there. Now, the new guidelines don't say never mind LDL. They say statins are good because they lower LDL. And they say you lower LDL with 2 objectives. 1, to reduce it by more than 50% in high-risk individuals, and 2 is to reduce it by at least 30% in moderate-risk individuals. So instead of goals where they say the LDL should be 70, should be 100, they go for make the patient drop at least 50% or drop at least 30% depending on risk category. Okay, so now you know what also the AHA and ACC said. They said, don't blame us, blame the literature, blame trial designs. We looked at all the evidence and we found that the evidence says 1 statin is better than placebo, 1 statin that's powerful, it's better than a statin that's less powerful, or the same statin at higher dose, it's better than a lower dose. So that's what you find in the literature. If we find more, we will expand our guidelines to introduce more. And more has come this year with finally the publication of the IMPROVE-IT trial. The IMPROVE-IT trial had support from Merck, which is the maker of ezetimibe, but it's a Jim Brownwald TIMI study. There is no funny business going on when Jim Brownwald runs a study. This was supposed to take 5 years, but it took 9 years for a series of logistical nightmares, including the fact that in 2009, there was a paper published in New England Journal of Medicine on a trial called ENHANCE. Does anybody remember the ENHANCE study? So the ENHANCE study was designed like this to give people simvastatin only or simvastatin and ezetimibe to see what would happen over a period of 2 years to CIMT. And what happened was nothing, and all hell broke loose. People thought this drug is useless because no changes in CIMT. So before validating CIMT in 2009, we believed that it has full power as a predictor of cardiovascular events. Now this study continued with a lot of trouble because so many patients were disenrolling from IMPROVE-IT, and at the end they show actually that by dropping LDL more than you would by simvastatin alone, and for one moment here, this is pleasing to the eye, but look at here, 70 versus 50, okay? If you see a patient with an LDL of 70, you probably take a picture, congratulate, and give them a little award. So here, it's always the academics versus real life. In real life, if you see a patient who has been stented twice, you don't like an LDL of 110, and you say, what should I do to bring it to a lower number? Here, in the academic world, is 70 may not be good enough. What happens if we take it to 50? So keep that in mind. But what happens if you take it to 50 is significant improvement in risk management. Now, again, if you just trust your eyes, you say, not by much, okay? But the point is not by how much. The point is it possible? Was it possible? Was it feasible to achieve protection in addition to a statin? The statin is such a powerful protector that not much has been able to show. Let's see if one spontaneously, no, okay. I was just hoping that somebody would choose the front row, because it will make you a good candidate for Department of Medicine chair one day. The person that spontaneously chooses the front row. All right, so this difference here is very pleasing for the cholesterol hypothesis. Okay, it means that you can take a 70, bring it to 50, and produce benefits. It means that you can. It goes against the fact that statins are the only things we need, because it's done with a non-statin medication. Okay, and it may show that in our approaches for risk reduction, it's not that smart to abandon LDL targets for LDL reduction in general, but just go back to a protection point for our patients. And the IMPROVE-IT trial falls in line with the results of other statin trials showing benefits with LDL reduction. So this is the IMPROVE-IT. It falls into this line from the cholesterol trialists group that has become almost a biochemistry line, where every trial has to compare to where the results fall on the line to see if the LDL cholesterol hypothesis is standing. Now, so up to now, statin utilizations via an endorsement via guidelines, maybe the possibility that an established non-statin medication like ezetimibe, which has 1 year left before it becomes generic, and in most formularies it's not very expensive. I think it goes with a minimum copay, can be used. But now let's look at why the field has been non-stop trying to produce new drugs. Okay? And the first one I want to show you is about how common is dyslipidemia. Like, everybody has it. What's the definition by the FDA of orphan disease? You know what's an orphan disease? An orphan disease is a disease that affects less than 200,000 Americans. Do you know what it means if the FDA makes a statement that a certain condition is an orphan disease? It means that if you are a drug company, you can produce a drug for an orphan disease in a short time, and you can charge a lot of money because you have a reduced market, right? So, is there an orphan disease in the field of hypercholesterolemia? Hypercholesterolemia is everywhere. So there is one, and it's homozygous familial hypercholesterolemia. Now, there are many ways to diagnose homozygous familial hypercholesterolemia. The simple one is very practical for you. Number one, just go to work every day thinking, I don't need to worry because I will never see one, and that's a safe position. Number two, you may one day say, am I actually seeing one? And that question should come if the LDL is like 400, 500, 600. Our highest LDL in a homozygote has been 900 at Vanderbilt. a 9-year-old girl who was the youngest recipient of bypass surgery. But so, since the FDA defines homozygous familial hypercholesterolemia as an orphan disease, there was an incentive to produce esoteric drugs that are not for your patients, okay? So you don't know about these drugs I'm talking to you about because they've been in the market for 2 years already, and I'm sure you have not prescribed one. But raise your hand if you have done it, because that will lead to a more interesting conversation. So, how do you remember what is homozygous familial hypercholesterolemia? Do you mind if I put you on the spot? If you don't avoid eye contact, I need to go after you then. What is homozygous familial hypercholesterolemia? It's the absence or near complete absence of LDL receptor. Okay? So it is a disease where you don't clear LDL from your blood. How can you fix that? Only by gene therapy, right? Because the clearance is this receptor that's membrane bound in the liver. There is no way of fixing it. You can't have a drug that makes the genes produce a protein that they can't produce. So we can't fix that. The fixing of familial hypercholesterolemia can be done on the other side. What if you tell the liver, don't make lipoproteins? Okay? So it seems pretty harsh, right? But these two drugs that are available for orphan diseases do one or two things. Either they block ApoB production, and ApoB is the protein of your lipoproteins, right? You remember that part. Your liver spits out lipoproteins into the bloodstream, and the lipoproteins are a sack of cholesterol and triglycerides with a huge protein that goes around it. That protein is ApoB. So if you stop the production of ApoB, the sack of lipids doesn't have anywhere to go. It stays in the liver. Or there is one transfer protein called MTP. Do you know MTP? MTP transfers the lipid droplet to ApoB. So it's the kissing facilitator. And if you stop MTP, the lipid droplet doesn't kiss ApoB. So either you stop ApoB or you stop the connection of the lipid droplet to ApoB, you don't have output. Your disease continues to be one of clearance. You can't clear, but if you don't put it into the bloodstream, you can drop your LDL by 50 or even 60%, okay? Now, the first one I show it to you just because it's a cool way and it's coming into your practices, not this one, in general. It's the antisense therapy. Raise your hand if you are that's the guy. I need to, I haven't seen in such a long time. How are you? I don't have time later, I need to run. That guy was with me at Vanderbilt, published beautiful papers, was really good into the basic sciences of things, and then it just did a 180, I was telling you, and became an interventional cardiologist. Go figure. All right, so you made me lose my train of thought. So do you know what's an antisense? You know what's antisense, right? Antisense is, think of your medicines. The medicines that you use, what are they? Aren't they inhibitors, mostly, blockers, antagonists? I think you have very few agonists out there. Human pharmacology is based on antagonizing what? Proteins. Okay? This is a new way. It's not allowing proteins to be made. So antisense means injecting a biological but not an antibody. It's a little strip of DNA, of antisense RNA, okay, maybe 20, 25 bases. And this thing, like anything you inject in the skin, goes into the blood system, goes into the liver. So the target must be the liver, of course. But this antisense finds the cognate, okay, in the cytoplasm. The mRNA, remember the mRNA, is it double-stranded or single-stranded? Single. So with the antisense, you make a double, and the double is not good because there are enzymes that will clip double-stranded RNA. So very simple. You basically produce an unnatural double-stranded RNA of your target template, and that gets destroyed with efficiency, and you make a lot less protein. Okay? So this is it can be done for ApoB, but it can be done for any protein produced by the liver, particularly secretory proteins. And this has been in the market by the name of Kynamro, Kynamro. But I will tell you that in the 2 years since launch, I don't think 100 patients in the US have been treated with it. And I will tell you how many with the other one. That's what you get with one injection, up to 60 or 70% reduction in LDL in homozygous familial hypercholesterolemia, people whose receptors did not work and continue to not work. Okay, you just stop the production. And you know, it works in homozygous FH, of course, not as well as in heterozygous FH, of course, because having clearance always helps. And the most common adverse events are injection reactions, where in the skin they can be staying for a long time, not quite good looking. So I think patients actually tolerate them okay, but they are not very, I would not like to have those blotches on my skin. And then, of course, the most important thing is if you tell the liver, don't put out the lipid droplet, then the lipid droplet stays in the liver, right? So fatty liver is common and transaminase elevations are common. Now, the other protein is a little bit simpler. It's an oral agent. So you take 1 pill a day, just like you do for a statin, and it blocks the MTP, as I told you before. By blocking MTP, again, the lipid droplet is not going to stick to ApoB. The difference here is that when you inject the antisense, it goes into the liver. It works only in the liver. When you take the MTP inhibitor, it goes systemic, so it affects the two organs that make lipoproteins, the liver and the liver and the intestine. So in addition to having the same side effects with possibility of fatty liver and transaminase elevations, you also have, these patients need to be on a very strict diet because they have steatorrhea otherwise. Because there will be, if you inhibit MTP in the intestine, you don't absorb fat anymore, right? Okay? Because the absorption of fat, remember, is based on rebuilding chylomicrons in the intestine. All right, so and this, if you do a full titration, you get into the, again, the 50% LDL reduction, except that most patients, because of LFT elevations or diarrhea, steatorrhea, stay with lower dosages, and they stay with maybe a 30% LDL reduction. And you can transform 10% of your liver into fat, or even more, like 15% or something. So this drug, this MTP inhibitor, was developed by Bristol Myers Squibb 25 years ago as a serious competitor for the statins, and then they dropped it because, of course, it couldn't be ever accepted by the FDA in the mass market, but it's accepted for orphan disease, where they give us what they call a REMS program, a risk evaluation and mitigation strategy, that we need to see the patients once a month. Now, the little thing I didn't tell you about these two drugs, an additional reason why you're not going to use them, is that the injectable is $175,000 a year, okay? And the pill, it's $250,000 a year, okay? So we have nationwide less than 100 users of the injectable and maybe 500 users of the pill. So you can see it's like very low volume and low utilization, but you need to know in case you find an LDL of 400 or higher, and you know, just I don't want you to start that medication. It's too much trouble. You just need to send the patient to somebody who's equipped to start that medication. Have you seen the news this week? Like yesterday? So yesterday the FDA approved the second drug in a new category of PCSK9 inhibitors. Be sincere. Tell me that you know PCSK9 and PCSK9 inhibitors. Raise your hand. No. 1, 2. That's half. Okay, if you go like, okay, 2. Okay, so the vast majority, 3, and a little bit. Okay, so The first one was approved here at the end of July, the second one yesterday. So Sanofi and Amgen are going like this, like lots of money coming in. So the PCSK9 agents are a little bit different from the ones I told you before. First of all, they don't go after production, they go after clearance, okay? Now the PCSK9 inhibitors are gonna improve your clearance, yours, mine, and that of people with heterozygous FH. Of course, you can't help a homozygous FH. If you don't have receptors, you can't help clearance. But if you have 50% of the receptors, you can help the clearance. So I'll show you how this works. In a way, just like I'm keeping an eye on the clock there and try not to make it too biochemistry based. Do you remember LDL receptor? LDL receptor is supposed to do one thing and one thing well, capture LDL, bring it to the lysosome, and go back to the surface. Okay? So if you are an LDL receptor, you know what you do? You do that hundreds of times. You grab a ligand, you bring it inside, clathrin-coated pits, invaginations, endosome. You get to the edge of the lysosome, you push the ligand in, and then you go back to the surface, repeat. 10 minutes, you have done back and forth, and you have hundreds of cycles. Goldstein and Brown, who won the Nobel Prize for the discovery of the LDL receptor, then they said, and then eventually the LDL receptor dies. Okay, but we didn't know how. Now we know how. The end of life for that stops the recycling of the LDL receptor is PCSK9. PCSK9 is a secretory protein. It's a proprotein convertase, but doesn't use any enzymatic activity to terminate the life cycle of the LDL receptor. What it does, it binds to LDL receptor just like LDL does. So if you are an LDL receptor and have taken a few hundred molecules, particles of LDL to the lysosomal destruction, and you're feeling pretty cocky, you go back to the surface and you say, and what are you? And PCSK9 says, oh, just another ligand. And you say, okay, come with me. And you bring it to the edge of the lysosome, and this other ligand says, I don't think so. You are coming down with me. So you have lysosomal destruction of the LDL receptor after binding to PCSK9. Pretty cool mechanism. Now, again, if I had asked in 1989, Goldstein and Brown, if I discover the reason, the mechanism that degrades LDL receptor, how important would that be? Their answer possibly would have been 10%. Maybe it can make a 10% difference in cholesterol levels. The difference is a lot larger than that. It's, let me see, it's about 60%. So if you inject an antibody to block your PCSK9 in the blood, in a few days, you start dropping massively your LDL. So what it means is actually that the LDL recycling, you were studying those things, right? So the LDL recycling is actually a vampire activity. If it wasn't for PCSK9, it will be eternal. So when we block PCSK9, this thing keeps on going. The LDL receptor recycles. There is no other mechanism. By recycling means removing LDL from the blood. So there are 3 humans identified without PCSK9 in the blood system. Their LDL is 19. It was completely unpredictable because 10 years ago we didn't know PCSK9, right? And now we have a new protein that manages to be the dictator of cholesterol trafficking. Okay? And it's good for therapeutical purposes because we block it and we see these fantastic changes. So what I skipped here fast was on the fact that they couldn't develop a small molecule inhibitor. So the best thing that they could do was antibody. So it's a biological, it's injectable, it's every 2 weeks, okay? And they both are approved. I have already 14 patients in my practice, and when I talk to other practices like mine around the country, they are prescribing at the rate of 1 to 3 a day in the preventive cardiology practices. Okay, I'll show you later how the FDA has approved it. But so you inject this antibody under your skin, the antibody will find PCSK9, all of your PCSK9 is associated with the antibody, therefore it cannot bind the LDL receptor. The LDL receptor has an Oktoberfest, just it keeps on going, and LDL cholesterol goes down. This is what gave impetus to the drug companies to go for it. This is from Helen Hobbs and Jonathan Cohen, showing that if you look at polymorphisms in PCSK9 that predict lower LDL levels, and this is it's not really a matter of race. It's not black versus white. It's the fact that in black there is one common mutation in PCSK9, but if that mutation is gotten by a white, produces the same thing. And the same is for the white people who have more commonly presenting with one mutation that reduces LDL a little bit less. But by getting a bunch of people in there when they are between 40 and 60 years old, and you just don't randomize for anything, like you grab them as they are with high blood pressure, obesity, and any family history or exposure, you just put them. You just look at whether they have inherited the PCSK9 mutation from birth. There is an incredible protection from cardiovascular disease. And so that led to this. The protein was not known 11 years ago. The first trial in human was 4 years ago. I think it's never heard for the FDA to approve for the mass market something so fast. Okay? So they're in the market for you now, and that's what you get, maximum dose with one of the two. The first one approved in July was from Sanofi, and this is the full dose. It's been approved as 75 and 150 milligrams every 2 weeks injection, and you can get as much as 60 or 65% reduction in LDL. If you try to stretch it, you cannot. If you try to do it every 4 weeks, you start having a zigzag. Okay, the zigzag may still be acceptable because look, the low point is minus 14. But in order not to get the zigzag, you need to do every 2 weeks. I think this is for now. Now, if you really, really read the news yesterday, what's ongoing in London now, it's the European Society of Cardiology meeting. So you can look it up. And yesterday there was a report from a clinical trial with another agent that reduces PCSK9 with the Antisense strategy. Remember the Antisense? So instead of blocking PCSK9 existing with an antibody, you go into the liver and you tell the liver to not make PCSK9. And these people are claiming that their product will be one injection every 6 months to keep your LDL below 50% from baseline. So you can see it's pretty much revolution of the way we have been doing things. Okay? Now, when I say 60 or 70%, this is not plus the statin. Then the statin has the power. Okay, so you can do 30%, 35% with the statin, 60% with this. There you go. The next time you're worrying about LDL being too low. So I think that's the big worry here, is that in a few years we're going to discuss if we are in a good spot by taking so many people to an LDL of 10, 20, or 30. And we'll bring many of them with these medications to that point. There is the reason why the FDA was so kind to them is because they didn't provide any evidence of adverse events. There is nothing. People are not complaining on the injection side. Maybe there is a little bit of flu-like syndromes, but there is, if you enroll statin intolerant patients, they tolerate this thing, even though it lowers LDL a lot more than a statin does. And this is just to give you an idea, just a spectrum of effects, okay? It's mostly an LDL effect, okay? You see this? But there is not much of an HDL effect or triglyceride effect. You want to know one thing? For the power of LDL reduction, the statins reduce triglycerides more than PCSK9 does. So it's an exquisite, because it has no effect on HMG-CoA reductase, on synthesis, on assembly. It's exclusively a clearance mechanism. But this one also, it's a study that to give you another little hint here, which is atorvastatin 80 or atorvastatin 10 are the same once you put the antibody. So our practice now, which is based on finding the right statin, stronger one better, increasing the dosage if needed, it's going to disappear because you see no difference anymore between Lipitor 10 and Lipitor 80 when you put the antibody in the mix. Okay? So I don't think there will be an incentive to stay high dose. There will be an incentive to go low dose of the right statin. Okay? And this is what I was telling you just to show you. The other one is called Evolocumab, and it shows the same thing. Look at this, 70%. These are statin intolerant subjects defined in the trial as people who have tried and rejected 2 statins for reasons of muscle pain or fatigue. Okay? The same. This is just for fairness. You know, basically there is no way today to discriminate the differential power of these 2 antibodies. They are equally powerful, and they reduce Lp(a) in addition to LDL equally. And now they don't have clinical trial evidence of cardiovascular benefits. They are still the studies are still in progress. So one may wonder why the FDA felt compelled for approving this thing. Okay, but with this kind of reduction, there have been 2 companion papers in New England Journal of Medicine in April of this year, showing that if you look at a series of studies together and you count the cardiovascular events, which is not the same as having a cardiovascular outcome trial. Okay, look at the numbers here, 209. So they are very low event rates, and they are not designed to respond to protection from clinical events, but it falls in the right place. There is a lot lower for the people taking the antibodies versus the placebo group, and the same goes with the other one. As I said, both studies were published. The New England Journal of Medicine in the last 3 years, I think, has reserved 5 blank pages just in case somebody wants to publish a PCSK9 trial paper. I was a reviewer for some of the papers, and I said, you know, enough is enough, right? We now they have made the point. The New England Journal of Medicine wanted every single one of them in a battle against Lancet and JAMA. They all want the headlines, you know, basically when it comes to this thing. But the FDA has approved it for for people who are on maximally tolerated statin therapy, if they have heterozygous familial hypercholesterolemia or clinical cardiovascular disease that requires additional lowering of LDL cholesterol. No target, no percent reductions, no numbers mentioned. So it's up to you. And you know, now this is valid for Evolocumab as well, that there is no evidence of cardiovascular benefits. There is also no evidence of side effects, particularly when you look at serious ones on behavior and central nervous system. However, when you look at non-serious one, there is a signal, and everybody has been careful to hide it or not to highlight it. And that there is a 3-fold increase in cognitive and memory impairment, not using a validated tool though, okay? Just asking patients and getting the responses. So there are trials in progress now using validated tools, and there are clinical trials for outcome studies. I'm freaking out with that message there, but I'm about finished with one additional category that needs a little bit of a historical presentation. They're coming into the market too, very likely. Okay, so you need to be prepared because it's also for mass market. You can ask me, but for the PCSK9 inhibitors, if you ask the companies, they will give you a free pen, injectable, just to test it to yourself and see what you have to explain to patients. But it's a self-propelled 1 ml volume kind of thing. So the patient will never see the needle. So there is a yellow tip to this pen, and once you make the yellow tip touch the skin and you click the button, then the needle goes in, and it's self-propelled. 1 ml goes in, then when you pull out, the needle goes back in. You never see the needle. Okay? Now the CETP inhibitors, does anybody know what CETP is or does? The endocrinologist, of course. But what about the non-endocrinologist? Except you, of course, because you studied on HDL so much. So CETP is the reason why you end the maturation cycle of your HDL. You know the way HDL is supposed to work? Start small, finish large, dump the load, repeat. Okay? So the HDL is not at all like the other lipoproteins. The HDL goes around, collects cholesterol. After a certain amount of cholesterol has been collected, doesn't want to collect anymore, wants to give it away. Gives it away to a receptor in the liver, or gives it away to other lipoproteins via CETP. It's a transfer protein. If you do studies, natural randomization studies to see whether CETP polymorphisms linked to different amounts of HDL cholesterol predict cardiovascular disease, you can say that sounds like a possibly good target. Having lower CETP activity means having higher HDL cholesterol, probably means being protected a little bit from cardiovascular disease. The problem with this is that we are now at the last 2 molecules to be tested in the market. The first one, does anybody remember torcetrapib? Torcetrapib was a Pfizer drug, and it was 2007 when torcetrapib was going to be the next blockbuster. And I had 44 patients of mine in a trial called Illuminate trial. It was a study where everybody took Lipitor, so no worries. But then you had either placebo or torcetrapib, and torcetrapib will raise your HDL by 65%. Hey, if you're lucky, you get it, right? That's what I was telling my patients, except that instead of 5 years to produce cardiovascular benefits, it took 10 months to produce cardiovascular harm. Okay? So, I don't know what, I'm summarizing a bunch of other slides that come next. So then I would just flip the slides fast. But then the conversation was, how can you raise HDL by 65%? You're taking Lipitor, it's dropping your LDL. You should be in a good zone, and actually it's bad. So the consensus solution was, you know what's bad? Torcetrapib is bad, not CETP inhibition. Torcetrapib, every molecule has the right to wreak havoc into your body, right? To have off-target effects. So it just so happened that torcetrapib was raising blood pressure, raising aldosterone, messing with electrolyte balance, and so it was an easy thing to blame. So CETP inhibition was agreed to continue on mostly because other companies were trying to chase Pfizer and saying, okay, you bring the first one into the market, I'll bring the second, I'll bring the third. And when the first one dropped, the other ones went like, okay, I just spent 25 million, what do I do? And so they decided to continue with their programs. The next in line was dalcetrapib, Roche. They felt so good. You know why? Because they were actually not producing a strong CETP inhibitor. So they went like, I don't even have a CETP inhibitor. I have a CETP modulator. We don't block CETP, we massage it, And so that was the new thing. They spent a lot of money for clinical programs. They had a portfolio of clinical trials. These are all slides that will come next. I just don't know. Let's see if you want to go there. This is the torcetrapib Illuminate. It was better to be on atorvastatin only than to be on something that raised your HDL by 65%. And this is the portfolio of Roche's trials. And do we have a biostatistician in the room? We don't need one, right? For this, look. So this one didn't show harm, but again, 5 years of raising HDL by 35% as atorvastatin is taking care of LDL, and you don't see anything? How's that possible? You know what happens if you apply a 35% differential on HDL cholesterol in Framingham? You get the largest differential in predicted risk that you can get out of anything. Okay? So how does it not work in a clinical trial setup? It's pretty strange. But so there are 2 companies now, Merck with anacetrapib and Eli Lilly with evacetrapib, saying ours will do it. And you know why they say that theirs will do it? Because of this. Now, remember I said 2007, it's good to inhibit CETP. The end of 2007, like, oopsie, is that poison? Then it becomes, it's good to massage CETP. Then, oopsie, that doesn't do anything. Now, the keyword is, yeah, we raise HDL, but hey, this is an LDL lowering intervention. Okay, so the two remaining CETP inhibitors are actually LDL reducers of quite a good amount, 35% or so. So they're better than ezetimibe. Okay, and they raise HDL, never mind, by a freaky amount. Okay, so you enter at 40, you finish at 100. Okay, so and there is a study going on, and the other one is evacetrapib, as I told you, 128% increase in HDL. But here too, the keyword is going to be this one is the reason why it's going to be good for you. So we'll see. Eli Lilly is preparing for an FDA approval at the end of 2016, actually. And these are oral agents, pills. It will be very interesting to see how in practice we accept the idea of giving a pill to somebody for lowering LDL and then saying, oh, by the way, this also increases your HDL by an enormous amount, and I don't know what that is, what that means. So, conclusion slide, I'm not reading it. I just give you the last 5 minutes for discussion, and thank you for not falling asleep. I don't think I've seen anyone falling asleep. Good. I would have responded to questions even without the applause. But the cost for which one? For the PCSK9 agents, I think they're claiming $13,000 a year. But the point is that CVS Caremark is different than MODA, is different than Medicare. So I think every payer will place it on a different position in the formulary with a different copay. So the companies have this strategy, which I hope is legal. I don't like to look into it, but I think it's FDA sanctioned. They have a company that is linked to them, but it's not them, that contacts the patient and makes sure magically that there is no payment. Okay, so I don't know how it works, but I have prescribed it to 14 people. We have received 3 approvals and 1 rejection. We don't know yet if patients are going to be very quick in telling us if they're paying too much. We'll see.
Thank you for the talk. It was excellent, and for bringing us up to speed with what the sustainability. And I was allowed to actually touch base on the cholesterol guideline, and it was there, right there. Previously, we were thinking somebody has disease, shoot for 70, less than 70 of LDL, or less than 100, and at least 70 if possible. Now, with this, we are liberalizing the concept of a statin use, and we shoot for an LDL as well. Please tell us whether it is consensus or expert opinion, observational, randomized. What is the current state of the field in terms of what is an LDL level at which we might harm a patient? Do we have?
Did you hear the question? The question is, with medications that can bring patients to very low levels, do we have enough data to know at what point we produce likelihood of harm? I tell you that there is definitely no information on cardiovascular benefits below 50. So I think that one should be your target. When Goldstein and Brown were doing their studies to see what's the minimum requirement for LDL, they came up maybe 40 years ago with 25, saying you don't want to drop to a circulatory level of LDL of 25, because in case one tissue, one group of cells is unable to provide cholesterol through synthesis and they need it through LDL, like the adrenals, for example, they may be limiting amount. Then, of course, there is that issue of hemorrhagic stroke, and there is the issue of cognition and memory. Those are all open things, open conversations. So I would say that in a high-risk patient where you start using these big weapons, the objective is to finally go where you say to a patient, and we don't need to talk about cholesterol. That part has been taken care of. For the same reason, you don't want to say, now we need to talk about cholesterol because this was unexpected that you had a hemorrhagic stroke, or it's so you don't want to be too much below 15. So I think the sweet spot, in my opinion, is going to be in the 50s range.
show the lipid data for the CETPs. Is the FDA going to require outcomes data?
Yeah. The FDA is not going to do see, that's a beautiful question because the FDA applies 2 measures to everything. So it's the FDA has approved the PCSK9 agents before proof for cardiovascular benefits. No way that they're doing it for CETP inhibitors. Okay, the CETP inhibitors will come into the market only when the FDA has seen the proof of cardiovascular benefits, which is still going to be a problem for you as prescribers because the proof is going to come from an LDL reduction of 35%, which of course should be good for you, but it also comes with this mystery elephant of raising your HDL by 100% and you don't know what it does. Okay, so they can say obviously it doesn't do anything wrong, but you don't know, right? So I don't expect this to become big sellers because of that thing.
So with all of the data coming out over the last couple of years, do you think the idea that HDL is good is an oversimplification of what's going on, or do you still?
No, I think if you go, and this has been done over and over again. Any population you go, you distribute HDL cholesterol levels, and you find the inverse relationship. The inverse relationship is always present. One can say that since we rely on biostatisticians to clean up that relationship, to remove the associated factors, and there are lots of associated factors with low HDL, diabetes, obesity, hypertriglyceridemia. There are lots of things that make the low HDL pool dirty, and we don't clean it up by removing the cofactors, but by asking algorithm makers to make some things that we never can replicate. So many years ago, I wrote an editorial saying, what if the HDL hypothesis is simply linked to the good lifestyle in population studies that produces the higher HDL? The biostatisticians tell us, no, we take into account lifestyle factors as well. But I don't know a biostatistician. I don't know what they do. Okay, I only trust data that it's verifiable and visible. The algorithms and big data, I am lost. You can't verify. So I was telling Dr. Reddy that we are back into the Framingham cohort, and I am presenting a paper for publication in JACC, where we are not biostatistical gimmick, just looking at low HDL, isolated low HDL, versus the vast majority of low HDL, which is accompanied with comorbidities. Okay, the common type of low HDL is 3 times more risky than the isolated low HDL. So there are 2 components out there. The HDL probably has the power to help us, but we need to help the vascular homeostasis, but we need to find the right buttons to push. It's obviously not by demanding for more HDL to stagnate into the blood. Okay?
Any other questions? Yes.
Sergio, I remember that. I had a discussion with Alan Paul. We were on the ran around the time.
2002.
Yeah, 2002. Maybe we take him out one-on-one with him for lunch. At this opportunity, I asked him, the question. I said, what is the rationale for the CETP inhibition? Because at the time, there were some Japanese families that were CETP deficiency, actually atherogenic. So he said, well, we went back and analyzed the data, and the really, really very deficient, those population actually atherogenic, partial deficiency actually protected. So then I'm part of that trial. I'm the PI for this, the second of this.
The Eli Lilly?
Yeah.
Okay.
So I was doing that, and on the PI meeting, I think Chris Cannon was the science guy, doing the science presentation. I said, tell me what percentage your compound actually inhibit the CETP? And he says it's very high.
Yeah.
So I said, well, that doesn't really make any sense. So it proved that now the complete inhibition or high-level inhibition probably not going to work. Yeah. That might be the basis now, the modulate, the inhibition. That might be something they can get out of. I'm still not sure if it's going to work. I want to know what is that Alan Toll and also Dan Rader, who's big advocate for that now, what they're thinking now.
Alan Toll, okay, did you hear him? Wentworth reminds me of the low talker in the Seinfeld episode. No. you have to go, oh, like, what is that? So he asked, like, what is the history of the CETP that a good expert like Alan Toll of Columbia Medical Center in New York years ago told him the secret is partial inhibition. The secret is being born with a partial defect in CETP, which means the therapeutic side is partial inhibition of CETP. So he says, after we discovered that torcetrapy was not good, the modulator idea was really excellent. And that at least didn't produce any harm. I think it actually advanced the field by saying it's not horrible to inhibit CETP in a modulating range, but it doesn't produce benefits. I mean, it's really worrisome it doesn't produce benefits. Now, the two remaining ones are philosophizing on reasons why they're still in the business. They're still in the business for one main reason, because they spent a lot of money. And they want to ride the molecule until it does something for them. Either it goes to nothing or it produces some revenues. But so now, as I said, the new connection is to the LDL reduction. And massive LDL, so what they're saying now is that when you look at humans with complete CETP inhibition, you also find that in some of them there is an LDL drop. And if there is an LDL drop, they seem to be protected. So that's now how they are justifying the new wave of clinical trials for these two remaining molecules. Okay? But it was so nice to see you. You haven't changed at all. You know, you need to, your hair must get gray.
I got gray.
All right, thank you.